We've covered amputations, arthritis, fractures, and more. Musculoskeletal health affects every aspect of patient care: mobility, skin, heart, and mental health. Don't just memorize, understand the why behind symptoms and interventions. Core nursing priorities: assessment, pain management, mobility, safety, preventing complications, and education. These principles guide your practice no matter the condition. Keep building your knowledge, review, practice, and think like a nurse. For more resources, visit brispainternational.com. Keep up the great work, and I'll see you in the next video. Hey everyone, Martin from Brispa here, ready to tackle another essential topic for your nursing journey. Today we're diving into musculoskeletal conditions. This is a critical area of study. It's crucial not only for your nursing career, enabling you to provide comprehensive patient care, but also for acing the NCLEX. Understanding these conditions thoroughly will significantly boost your confidence on exam day. Our bones, muscles, and joints allow us to move, to work, to play, and ultimately to live fulfilling lives. They are the foundation of our physical well-being. When something goes wrong with this intricate system, it impacts everything, from daily activities to overall quality of life. As future nurses, you'll encounter patients with a wide spectrum of musculoskeletal issues, everything from fractures sustained in accidents to chronic autoimmune diseases that affect the joints and connective tissues, causing pain and disability. The NCLEX tests your ability not just to recall facts, but to apply your knowledge to provide safe, effective, and compassionate care in these complex scenarios. You'll need to demonstrate critical thinking and sound clinical judgment. Musculoskeletal questions cover a broad range of topics, including pain management strategies, both pharmacological and non-pharmacological, mobility and range of motion exercises, infection control, especially crucial in post-operative care and wound management, patient safety protocols to prevent falls and injuries, and comprehensive patient education to promote self-management and adherence to treatment plans. For example, a question about amputation isn't just about the surgical procedure itself, it's about preventing post-operative complications like infection and phantom limb pain, and providing holistic support to the patient, addressing their emotional and psychological needs as they adjust to a significant life change. In this guide, we'll break down high-yield topics, focusing on the most commonly tested musculoskeletal conditions on the NCLEX, including amputation and the nursing considerations surrounding it, Scleroderma, a chronic autoimmune disease affecting the skin and other organs, Fibromyalgia, a widespread musculoskeletal pain accompanied by fatigue, sleep, memory, and mood issues, fractures and their various types and management strategies, osteoporosis, a condition characterized by decreased bone density, increasing the risk of fractures, osteoarthritis, a degenerative joint disease, and rheumatoid arthritis, a chronic inflammatory disorder affecting many joints, including those in the hands and feet. My goal is to make these complex topics clear, memorable, and most importantly applicable to your future nursing practice. So grab your notebook, find a quiet space, and let's get started on mastering musculoskeletal health for the NCLEX. We'll connect the dots between the underlying pathophysiology of these conditions, the lived experience of patients dealing with them, and your crucial role as a nurse in providing comprehensive and compassionate care. Let's build your confidence, expand your knowledge, and pave the way for your NCLEX success and a rewarding career in nursing. Let's start with amputation, the surgical removal of a limb, usually as a last resort. Most often it's due to poor circulation from diabetes or severe trauma. Before surgery, tests like the ankle brachial index and Doppler studies assess blood flow and help determine the best level for amputation. Key risk factors: diabetes, smoking, peripheral artery disease, severe injuries, and chronic infections. Nurses play a vital role in patient education, especially about foot care and blood sugar control for diabetics. The goal is always to remove diseased tissue while preserving as much function as possible. Understanding these basics helps you anticipate patient needs and plan effective care. Let's discuss complications following amputation. Common complications include infection at the surgical site, delayed wound healing, hemorrhage, and deep vein thrombosis. Phantom limb pain is also a significant concern, as well as contractures, which can limit mobility. Psychological effects such as depression and anxiety are important to address. Early recognition and intervention are key to preventing long-term disability. Pre-operative care for amputation focuses on patient education, psychological support, and optimizing medical conditions such as diabetes or vascular disease. It's important to assess the patient's understanding, provide emotional support, and ensure informed consent. Pre-op teaching includes exercises for upper body strength and what to expect after surgery. Post-operative care involves monitoring for complications like infection, bleeding, and contractures. Pain management is crucial, including both pharmacological and non-pharmacological methods. Early mobilization, physical therapy, and proper positioning help prevent contractures. Emotional support and connecting patients with support groups can aid psychological recovery. Once amputation is planned, pre-op care is about preparing the patient physically and emotionally, educate about what to expect, reinforce the surgeon's explanations, and answer questions. Ensure informed consent and stabilize health issues like blood sugar or blood pressure. Teach upper body strengthening, crucial for post-op mobility. After surgery, monitor for hemorrhage and shock. Check dressings, drainage, and vital signs. Keep a tourniquet at the bedside for emergencies. Prevent infection with aseptic technique during dressing changes. Prevent contractures. Avoid pillows under the knee. Encourage prone positioning to stretch muscles. For above-the-knee amputations, avoid prolonged sitting. These interventions are vital for long-term function and recovery. Phantom limb pain is a very real and often debilitating experience for individuals who have undergone amputation. It's not just a figment of their imagination. It's a complex neurological phenomenon that requires understanding and compassionate care. Phantom limb pain presents a challenging aspect of amputation care, demanding a multifaceted approach to alleviate suffering and improve the patient's quality of life. It requires a dedicated healthcare team. It's primarily caused by the brain and the intricate network of nerves, which continue sending signals to the area where the limb used to be, even though it's no longer physically present. The brain's neural pathways are still active, mistakenly sending signals to the missing limb, resulting in the sensation of pain, tingling, or other discomfort. It's crucial to acknowledge the pain and treat it seriously, validating the patient's experience and demonstrating empathy. Dismissing their pain can be detrimental to their recovery. NCLEX expects you to know this, so be prepared to address phantom limb pain in your nursing practice. Understanding its causes and management is essential. Pain management often involves medications like gabapentin or amitriptyline, which can help modulate nerve signals and reduce pain intensity. In addition to medication, non-drug methods like mirror-therapy, which helps trick the brain, and therapeutic massage can provide significant relief. Remember that amputation is also a profound psychological event, often accompanied by grief, loss, and body image concerns. Therefore, it's vital to assess their coping mechanisms, identify available support systems, and understand their emotional state. Be vigilant and watch for signs of depression or anxiety, as these conditions can significantly impact their recovery and overall well-being. Create a safe and supportive space where patients feel comfortable expressing their feelings, fears, and anxieties without judgment. Connect them with mental health professionals, such as therapists or psychiatrists, who can provide specialized counseling and support. Encourage participation in support groups where they can connect with other amputees, share experiences, and learn coping strategies. Your ultimate goal is to help patients adapt to their new circumstances, regain independence, and improve their overall quality of life. Focus on their strengths, celebrate their achievements, and promote independence in all aspects of their lives. Providing compassionate support early on in the recovery process is absolutely essential. This sets the stage for long-term well-being, fostering resilience and empowering them to live fulfilling lives. Remember, recovery is a marathon, not a sprint. It requires patience, perseverance, and ongoing support. And in this journey, your role as a healthcare professional is absolutely crucial in guiding and supporting them every step of the way. Now, let's talk about connective tissue disorders. Many are autoimmune. Connective tissue is the body's framework found everywhere from bone to blood. In these disorders, the immune system attacks healthy tissue, causing chronic inflammation and systemic problems. Symptoms can affect joints, skin, kidneys, lungs, and more. For NCLEX, remember these are systemic diseases. Assess the whole patient. Goals of care: manage pain and inflammation, suppress the immune system, and educate patients. These are lifelong conditions. Support and education are key. Empower patients to manage their disease and make informed choices. Holistic care is essential. Focus on scleroderma and fibromyalgia for the NCLEX. Scleroderma means hard skin. It's an autoimmune disease with excess collagen, causing tight, shiny skin and sometimes organ damage. Remember CREST syndrome, calcinosis, Raynaud's, esophageal dysfunction, sclerodactyly, telangiectasias. Severe cases can affect lungs, heart, and kidneys. Care: manage symptoms, protect organs, maintain mobility. Fibromyalgia is a pain processing disorder. Chronic widespread pain, fatigue, sleep issues, and fibrofog. Diagnosis is by exclusion. No single test confirms it. Management: medications for nerve pain, stress management, and regular low-impact exercise. Patient education and support are crucial. Focus on improving quality of life. Raynaud's phenomenon is common in scleroderma. Management includes keeping hands and feet warm, avoiding cold exposure, and using medications like calcium channel blockers to improve blood flow. Stress reduction is also important. Severe cases may require advanced therapies. Sjögren's syndrome can occur with scleroderma, causing dry eyes and mouth. This increases the risk of dental problems and eye irritation. Management includes artificial tears, saliva substitutes, good oral hygiene, and regular dental care. Monitoring for complications like dental caries and oral infections is essential. Fractures, breaks in bones, are common in nursing. Causes: trauma or weakened bones from conditions like osteoporosis. Signs: pain, swelling, bruising, loss of function, deformity, and sometimes crepitus. Confirm with X-ray. Treatment: reduction, realigning bones, then immobilization with a cast, splint, or hardware. Nursing care centers on the 6 Ps: pain, pulselessness, pallor, pressure, paresthesia, and paralysis or paresis. Compartment syndrome is a serious complication of fractures. It occurs when increased pressure within a muscle compartment reduces blood flow, leading to tissue damage. The hallmark signs are the 6 Ps: pain out of proportion, pulselessness, pallor, pressure, paresthesia, and paralysis or paresis. Early recognition is critical. Severe pain not relieved by medication, especially with passive stretch, is a red flag. Immediate intervention, such as fasciotomy, may be needed to prevent permanent damage or limb loss. There are several types of fractures: closed, simple, open, compound, comminuted, green stick, spiral, oblique, transverse, and impacted. Each type has unique features and implications for treatment. Open fractures have a higher risk of infection, while comminuted fractures involve multiple bone fragments. Let's talk about how bones heal after a fracture. Bone repair occurs in 4 main stages. First, a hematoma forms at the fracture site as blood vessels break, creating a clot and inflammation. Next, a fibrocartilaginous callus forms as new blood vessels grow and soft tissue bridges the gap. Then a bony callus forms as the soft callus is replaced by hard bone. Finally, bone remodeling occurs where the bone is reshaped and strengthened over time, restoring its original structure and function. Understanding these stages helps you anticipate patient needs and recovery timelines. Traction is used to align bones, reduce muscle spasms, and maintain position after a fracture. Types include skin traction and skeletal traction. Nursing care includes monitoring alignment, ensuring weights hang freely, checking skin integrity, and assessing neurovascular status regularly. Complications of fractures include compartment syndrome, fat embolism, deep vein thrombosis, infection, delayed union, and non-union. Early detection and intervention are essential to prevent long-term disability. Care of a client with a cast includes keeping the cast dry, not inserting objects inside, monitoring for swelling, pain, numbness, or discoloration, and elevating the limb to reduce swelling. Teach the patient to report any signs of impaired circulation or sensation immediately. When using crutches, the arm piece should be 1 to 2 inches below the axillae to prevent brachial plexus injury. Never rest with axillae on the arm piece. Gait patterns include 2-point, 3-point, and swing-through gaits. For stairs, up with the good, down with the bad. Sit by backing up to the chair, holding both crutches in one hand and lowering yourself slowly. After hip fracture repair, avoid hip flexion beyond 90 degrees. Do not cross legs and use an abduction pillow if prescribed. Monitor for signs of infection, DVT, and encourage early mobilization as advised by the healthcare team. In Scleroderma, dietary considerations include eating small, frequent meals, avoiding spicy or acidic foods, and sitting upright after eating to reduce reflux. Soft foods may help with swallowing difficulties. Adequate nutrition is important to prevent weight loss and malnutrition. Fracture management often involves reduction, realigning the bone, and fixation to maintain alignment. Closed reduction is done without surgery, while open reduction involves surgery. Internal fixation, ARIF, uses plates, screws, or rods inside the body. External fixation uses a frame outside the body attached to the bone with pins. Both methods stabilize the fracture and promote healing. Pain, pallor, pulses, paresthesia, paralysis. Check frequently. Watch for compartment syndrome, severe pain not relieved by meds. This is an emergency. Other risks: infection, blood clots, and fat embolism. Early detection and intervention are critical. Your assessments can save limbs and lives. Always prioritize neurovascular checks. Alright, let's dive into another quick fire round, hitting some key musculoskeletal conditions you're likely to encounter: scoliosis, osteoporosis, and arthritis. We'll break down the essentials of each, focusing on what you need to know for patient care, and of course, the NCLEX. Scoliosis is a sideways spine curve, an abnormal lateral curvature of the vertebral column. Often in teens, it's frequently diagnosed during adolescence. Mild cases are monitored with regular checkups to ensure the curve isn't progressing. Severe ones may need bracing or surgery to correct the curvature and prevent further complications. Osteoporosis means weak, brittle bones, a decrease in bone density, making them fragile and prone to fractures, often silent until a fracture occurs. These fractures commonly happen in the hip, spine, or wrist. Risk factors: age, female gender, particularly postmenopausal women are at higher risk. Family history, a genetic predisposition can increase your chances. Low calcium, inactivity. A sedentary lifestyle contributes to bone loss. Prevent fractures with meds, weight-bearing exercise which helps strengthen bones, and calcium vitamin D. These are crucial for bone health. Arthritis, osteoarthritis, OA, is wear and tear, the most common type of arthritis, resulting from the breakdown of cartilage in the joints, affecting weight-bearing joints like the knees, hips, and spine. Pain worsens with activity. It's important to manage activity levels to avoid exacerbating the pain. OA management, pain control, physical therapy to maintain joint mobility and strength. Healthy weight, reducing stress on the joints. Rheumatoid arthritis, RA, is autoimmune, a chronic inflammatory disorder affecting many joints, including those in the hands and feet, causing joint swelling, morning stiffness which can last for hours, and systemic symptoms. Fatigue, fever, and weight loss are common. RA treatment: DMARDs to suppress the immune system. Disease-modifying anti-rheumatic drugs can slow the progression of RA. Your role: manage pain, preserve function, and promote independence. Educate patients about their condition and treatment options. Gout uric acid buildup causes sudden, severe joint pain, a type of inflammatory arthritis, often in the big toe. This is known as podagra. Know the basics for each, understanding the pathophysiology, risk factors, and management strategies. NCLEX loves these topics, so make sure you're well prepared.